We're going to start with the hospital response, okay? That we are very fortunate enough to have Diane on board and start our program for the afternoon. And we're on the home stretch, everybody. So, okay, go ahead.
Okay, thank you. So again, a very, very spirited discussion. So these are the slides for the 3C breakout. Okay, I can do this.
I do that.
There we go. So this was, we were concentrating on recommendation 4 on response of hospitals to cardiac arrest. And in the report, we specifically called on the Joint Commission in collaboration with several other organizations to develop and implement an accreditation standard for healthcare facilities specific to cardiac arrest care for both adult and pediatric populations. We started our discussion with discussion of the major barriers and challenges to implementation of any kind of set of standards, and as you can see here, the lack of potential hospital leadership, resistance to publicly reported data, and then really inadequate data, lack of national standards. We lack a data dictionary for this. Inadequate specificity of codes to distinguish between in-hospital and out-of-hospital cardiac arrest. There also are inadequate codes, CPT codes, for the therapies that might be delivered for cardiac arrest. The challenges of risk adjustment. Not all hospitals will have same equivalent patient acuities, and that needs to be adjusted for. There's a major difference between the standards and metrics, and we were very fortunate to have a member of the Joint Commission to help us understand the difference between standards and metrics. And this issue that we all get into, and we got into a little bit in our group, of analysis paralysis. Whoops. Okay, so the stakeholders that we thought were important to bring into this discussion include obviously the Joint Commission, NQF and CQA, federal agencies, primarily CMS, industry, our professional groups, the Hospital Association, Heart Association, the Children's Hospital Association, Society for Critical Care Medicine, which we haven't really talked about too much so far, Hospitalist Medicine, and the American Academy of Pediatrics. And once again, patient and family groups that as hospitals publicly report their data, patients are choosing which hospitals they would like to use. And then the ICD and CPT code organizations. We initially had this slide titled as Strategies to Implement Accreditation. And as the discussion went forward, we realized that we probably are not quite ready for that yet, and that we should start more with something that was called hospital recognition for methods of process improvement. We have some of that already. Get with the guidelines for resuscitation, for stroke, for MI, have various awards for hospitals based on their level of participation and their achievements in certain benchmarks. And that provides, the benefit would be a soft launch for hospitals. Don't go directly to the specifics of accreditation based on certain metrics that they may not be quite ready for. The challenges are that these are completely voluntary. A lot of discussion that perhaps we should start with something called cardiac arrest ready hospitals with cardiac arrest centers of excellence. All hospitals have to have some capacity. This includes early warning and recognition, that they are event ready, meaning that they can at least deliver the basics of CPR and early defibrillation and early post-arrest care, and then the more specialized hospitals. After our discussion, there were a few of us, I'll give full credit to Graham Nickel for getting us started on this, that we can, instead of calling them cardiac arrest ready hospitals, we can give them an acronym. And together we came up with SPARK, which is System to Prevent and Actively Resuscitate Cardiac Arrest. And then perhaps once we have done those two things, we can get to the process of actually establishing metrics that would provide standardized evidence-based care. It would help with team training, and it could be tied in with patient safety initiatives. The challenges are the challenges that all hospitals have with process variability. There are technological challenges, and we have, as of yet, not defined denominators for hospital, and that needs to be done very quickly before we can actually establish specific metrics. And we spent a lot of time, we were fortunate to have Mark Alberts from the Brain Attack Coalition talking about the need to create a coalition for cardiac arrest. We talked about creating a playbook similar to the antibiotic stewardship. The benefits, this is going to be providing a roadmap, and we're very fortunate that this is going to be our next discussion this afternoon, and so I'm not going to go into any more detail. Thank you.
So what I think we're going to do is, then, since we have to, or you want to come on up? Yeah. Since we're going to have to move along and get this done because we have guest speakers and so on coming at like 1 o'clock, we'll try to take a series of questions from Diane and the rest of the panel after they've done the three quick briefings. So Art, you're the next one. You're doing one on
continuous process improvement.
He's doing something on continuous process improvement. Okay, thank you very much. Welcome, Art Sanders.
Thank you, and I'd like to thank everyone who attended. We had a very lively and good discussion. Again, we go recommendation 5, asking for responsibility, authority, accountability, and process improvement in all systems, both inpatient and out of hospital. Oops, this is the wrong slide. Yeah. Sorry. Okay, so we have 3 focus points. One is financing of the EMS system. We're asking that we need to reassess how EMS is financed. Right now, it's financed as not as providers, but as suppliers, and there's really no incentive to do a quality job. You get paid just for transporting patients, and so the key players will be the Health and Human Services and Department of Transportation through NHTSA. And we feel that we need to lobby for EMS as a provider rather than a supplier of healthcare, and build in incentives for quality of EMS care to align with the future of where all healthcare is headed to value-based healthcare. And what we're advocating would go nicely with this new model. Our second point focuses on messaging. Yesterday we spent much of the afternoon discussing messaging for CPR, public, school children, other sorts of things. But right now, nobody's really doing the broader messaging for EMS services. And so we need to think some organizations or the collaboration or somebody needs to develop messaging to, one, show the magnitude of the problems, like Vinay showed 2 747s crashing every day, 2 buses full of children crashing every day. And then the question, you know, what is your number? Your chance of surviving depends on where you are and what is your number. And the thought is this will bring pressure by holding systems accountable, that the public will want to hold systems accountable and eventually provide resources for this. So delivering that message should be a key element of what we do. And our third focus point is to help build and expand the infrastructure for incentives and information exchange for providing CQI in the EMS systems. Now, there are some demonstration projects like Heart Rescue, the Resuscitation Academy, the Utah program, EMS Compass, that was described this morning, but they're limited. They're limited to so many states and so many things. This needs to expand. The ones that are out there are successful, and building on that in a more national level is real important. We need to build leadership and champions on the local level to promote this culture of improvement and innovation. and we need to provide performance measures to solve local problems. So the performance measure may differ depending on the local situation, but everyone should be following the performance measure based on the data they produce. Part of the things we discussed was that even just this information exchange, for example, the various organizations like the heart meetings and resuscitation sessions could have part of the time designated to what's going on in various sections. These might not be peer-reviewed papers, but it might be an information exchange or other things like EMS organizations, NAEMSP, or other organizations providing that interchange. So in summary, we recommend these 3 points: the infrastructure, the financing, and the messaging. Thank you.
I helped to coordinate this section on dispatcher and telecommuter CPR, and it actually was a great group of people and a lot of bright people in the room. We did pretty well. Can we go into the next slide, please? Or I guess I do that, right? Okay, here we go. So we were supposed to look at recommendation number 3, which was to address with the National Highway Traffic Safety Administration, otherwise known as NHTSA, okay? To help out with this and convening interested stakeholders to develop standardized dispatch-assisted CPR protocols and national education standards for use by all public safety answering points, and establish standardized definition and training curriculum for high performance to be used in basic EMTs training and certification. So we pretty much covered this first part here. That was our area. We thought our area was to cover the response to real-time CPR through telecommunications or whatever. Hello, tell my mother I said hi. Can you go to the next slide, please? Okay. It's been tweeted out. All right, so here are some of the, we were supposed to address major barriers and challenges and so on, and part of it is that, as someone said earlier, that there's about 50% of the places in the United States don't even have like dispatcher, EMD, and so on there, and many states, for example, we heard, don't have this, so that's a whole issue in itself. But having said that, as you heard, part of the recommendation was to convene and develop a national action strategy, and specifically, we call for NHTSA to organize these folks in our recommendations, but we're saying, let's do it that encourages, PSAP performance training skills and so on. Having said that, they've already got the ball in motion to do this, but they're going through their typical budgetary cycle, so it would not be a bad idea at this point in time for us to, as an organization here, and even as individuals, to encourage that budget cycle be approved, that they can convene a meeting to get all the stakeholders together to help address some of the things we're about to talk about here. So one of the interesting things that we came across was the concept of regionalization of centers. So for example, in any given city, you might have great PAIs, that is pre-arrival instructions, or great telecommunication CPR, and others you may have nothing, or a person who doesn't do it all the time or doesn't know how to do it. And so one of the things that they've done in certain states has actually to have a centralized, for example, if they make the dispatch run, they're on their way, they say, okay, stand by, and they transfer you to talk to somebody else in that region, or it could be a whole state, where you're talking to a centralized person who that's their job. They do telecommunications, CPR, dispatch CPR. And in the future, we'll talk about ways we may even use technology to actually look at what's going on at the scene. So the dispatcher who in the past has been blinded now could have the equipment, or maybe with FaceTime or whatever, could actually see what's going on in the scene, or even in return tell that person, here's how you do the CPR or whatever it might be. So there's a lot of interesting aspects that might come out of all that. So to achieve that goal and justify that approach, we obviously will need to research it. And so one of the first things we suggested as an action item here is to explore model policies and programs to expand dispatch CPR and emergency medical dispatch services, such as the New Jersey law that came in that required a centralized approach to this. So there's cool models out there, and it got there by legislation. So we want to do a kind of an inventory of what's out there, what's available, what are best practices that we can mimic and explore those. Now, so that's sort of the first part what we want to do is encourage that we start addressing this. Now, let's get down to the weeds a little bit. One of the things we also want to look at is encouraging standardization of CPR protocols, but maybe also with flexibility. There are existing programs right now, but we have found that if you now address those or change those or look at different ways of exploring them, maybe in a responsible fashion, that may be the way to go. Other places have actually improved their survival rates because they've tried alternate approaches to the standardized models that are out there and so on. Like one of the approaches that seem to have worked really well in their reports back from places like Anchorage and Los Angeles and others, by using a no-no-go. And so instead of using a whole series of questions, they get right to the point and say, is the person awake or awakeable? You know, no, okay. Is the person breathing normally? No, then go, okay? And so those are the kind of things that we found out when people were intrepid enough to go ahead, let's change the protocol and try something new, and they documented that it improved outcomes. That's been a cool thing. All right, so one of the things that probably should go up above with the regionalization approach or exploring models was the issue that we might want to interact with national conferences of state legislators, because we can see how they get legislation done and, you know, just start coordinating with those folks, and that may be a way to help, especially when we maybe invite them to the NHTSA meeting and so on, and that may be part of our inventory up front as we do this, okay? Next slide, please. One of the overriding things was to improve EMS Medical Direction involvement in PSAPs, because when that's happened, it's improved the outcomes. And so that was a strong recommendation. But probably if I was to stop here and say, was there one single thing we would take home, everybody in the room said, we've got to make sure there are dedicated people doing quality assurance for dispatch, that there has to be dedicated personnel who are doing training, CQI, or whatever it is, but they are there listening to calls. And that's why part of that goes back to the regionalization thing and looking at models such as Arizona or New Jersey or whatever, where you have people who are specialized in this and can give the feedback and say, hey, you're doing it well or not doing it so well. But everybody agrees that the quality assurance with feedback training loops are just really critical, and that's what's made a difference in many places and so on. The advantages of this may be that you're achieving economies of scale, et cetera, and that may be another purpose for doing this. One of the things that came up was revisiting the pre-arrival instructions, including logistics. Do you actually pull somebody off the bed when it's an older man? Is that important? You know, and the wife is trying to do that. Some of the things of having machines that say, now, 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 for pushing on the chest. By having you know, the timing there at the dispatch office and minimizing what they have to do, and other things that will help improve the quality of the dispatch system. And also maybe adopting and adapting and modifying to systems to better manage underserved different demographics and language barriers. So if you have someone calling in, they need pre-arrival instructions, and again, that may go back to the regionalization. It improves it because you have experts there. And it's not just English and Spanish, there's so many other languages to learn, and cultures as well. There may be different languages, different approaches, and encouragements depending on what it is. And then finally, some of the things that we said to help that is to consider external accreditation processes for dispatchers that will actually, you know, maybe put people on the spot, or even local politicians or budget cycle people to say, hey, we're not up to snuff, and that might be another way of doing it by having an external force come in and do that. They're also saying that we should do better promotion and coordination with, like, if you have a large facility and you have to call this security guy in that place, or you're in an arena, how is the interface with the dispatcher? How does that work if the dispatchers are getting called from 911 from someone in the audience versus the CEO? So having plans that better coordinate that should be done at various levels, and even with private ambulance companies that might get called, et cetera, in different locations. So, and then the main things are, in everything we do here, pursue research and promote adoption of emerging technologies such as smartphone apps where they identify that you're near an AED or there's someone who needs CPR. And one of the suggestions we got was that when people do their CPR training, tell them about that app so they can now be part of the rescue team out there. And so if they get there's various companies that have a thing and say where an AED is, they know about it. They can even be alerted that there's a cardiac arrest and there's an AED nearby. So you could go and get that. And then eventually maybe developing a location registry for defibrillators, particularly in high trafficked areas for the dispatchers, so they will know, and that will help all those things we just talked about previously. And finally, make sure there is outreach to communities, organizations, foundations, churches, and address the cultural aspects of things. For example, that people may feel that they shouldn't do this or could, and make sure you're out there encouraging people to just do it. As Lance has always said so often with the Nike approach, just do it. And I've heard that so many times from folks that, we got to encourage them to get in there. And then last but not least, there was a impressive, I think, I heard it from people, that there has to be a better way to address the culture and motivation of EMDs. And so it sounds, I work with great EMDs in areas where I am, but there is enough of it around where in many places that there has to be an improvement in their attitude and their motivation to help with it, because many times there is a delay in getting the CPR instructions done because they're even afraid to give the orders. So we've got to be able to get on top of that and get them to do a better job. So with that, I'm going to stop. And I'm Paul Pepe, and I approve this message, okay? So I think at this point, we'll take some questions. And thank you very much, everybody. And thank you, the group that put this together. Thank you so much. That was a terrific, really terrific effort today. So thank you. Okay. All right, so any questions from the Dr. Augustine? Tell us who you are and where you're from.
Augustine, emergency physician from Atlanta and other places. Diane, specifically to you. Hospital cardiac arrests, in trying to do this locally, there's a big difference between inpatient cardiac arrest and a community cardiac arrest that happens to occur on a hospital campus. And really different ways to approach it, both physically and then data-wise. And then a children's hospital that has one of their employees or the grandparent of a child that goes down and happens to be cardiac arrest somewhere on the campus. There's these huge campuses now, and we have cardiac arrests, and really, frankly, 911 systems are in much better condition to respond and provide service and transport out of upstairs buildings that are on hospital campus. Did you consider that as part of your deliberations, and how both measures to approach and then to monitor quality will need to take place?
So let me clarify. You're asking about a cardiac arrest that may occur within a hospital, but it's not a patient.
Yes.
Is that? No, we actually did not.
It's a big issue, and then we again, thinking two different things. There are people who are family members of patients who collapse.
Mm-hmm. Yes.
And you send the code team there and you address them, but they frankly are a community cardiac arrest. Mm-hmm. There is a really huge difference in somebody who's in one of the hospital campus buildings and goes down in cardiac arrest, and the ED team or the code team is trying to get to an off-site building where they're frankly not equipped to get a patient down and out of that building. Calling 911 from the hospital campus is the very best thing that can happen. And it's very different. Inpatient cardiac inpatients, and one could even consider inpatient on a floor inpatient, in the cath lab inpatient, in the ORs, very different approaches to who's responding, what the things are. And frankly, cardiac arrest in a hospital should all be about prevention and not how to go and resuscitate.
And that is one aspect that we did not consider.
Okay.
But I think you're right. Most hospitals do need to be prepared for that.
Yep, and it really is very important to everyone. If
Yes.
there's an off-site building that's still considered part of the hospital campus,
Right.
call 911. Thank you.
Just one thing on that. Tim Noonan, I'm a paramedic. I used to teach at a bunch of hospitals, ACLS, and one of the things I would get from people on their emergency response team is at some hospitals they were told, do not touch anybody who does not have a patient ID band on. They are not patients, so if they drop cardiac arrest, shortness of breath, seizures, doesn't matter. You're not supposed to touch them until they're registered. That can be a problem. It's a lawyer who has, some sort of worst case scenario that's out of a movie who seems to have done that, but we need to get people to use common sense.
So I think that, I think both points are very valid, and that is an individual hospital response that I can tell you, I sit on our hospital CPR committee. We actually have a process for that. We know because it's a huge facility, and that's, I think, a very individual thing because it's going to be very dependent on local factors.
It was just one of the hospitals that I taught at, and I used to, get comments from the emergency response team because they had to take the ACLS there, and there are all sorts of rules like that.
This is kind of a common theme of certain obstructions or verticals, like the AEDs, where it says only to be used by trained personnel. Oh, okay, and so is that me? And something, if you hesitate a lot, there's a lot of things that, and I guess the answer to most of these, in general, whenever I've come across bizarre things like that, it's like, if this was my family member, what would I do? You just try to do the right thing. So, but I'm glad you're making us aware of those kinds of issues that we've got to address, maybe. Dave?
Dave Slattery from University of Nevada, emergency physician and medical director for City Las Vegas Fire Rescue. This topic came up during our session, but I think it's apropos, Paul, for your last bullet point. I think it's important, worth stating, is that the importance of our dispatchers, our 911 communication specialists, as well as our paramedics, getting feedback on the outcomes, and especially our communication specialists, driving that improvement. Part of that incentivizing, as Ben Bobrow had mentioned, for our dispatch-aided CPR is letting them know what those outcomes, because too often they pick up a phone call, they give dispatch-aided CPR instructions, they hang up and pick up the next call. And both for their well-being as well as their education motivation is a really important thing to make sure we capture.
And that's it. And I think that was remember I said the main driving thing was to have a dedicated person who does follow up, listens to the calls, gives some feedback, and that can give, and the outcome should be part of that. And so we absolutely agree with that. Go ahead.
Scott Keir, I'm paramedic in Newcastle County, Delaware, and part of the EMS Compass project. Diane, just curious, was there any talk in your group about approaching in-hospital cardiac arrest in a similar fashion to out-of-hospital cardiac arrest, or even going as far as reaching out to pre-hospital providers for training to improve the quality of in-hospital cardiac arrest? And if not, how do you feel about that?
No, there was not. I think it's a great idea. Paramedics, I think, perform CPR quite well, and using them as instructors, perhaps even monitors, or even as a part of the cardiac arrest team. I think those are all valid considerations for in-hospital preparedness.
Thank you.
It's Peter Antevi from South Florida, Pediatric ER and EMS Medical Direction. So you just stole my comment. So thanks for that. But it's kind of a running joke amongst EMS medical directors that if we have a cardiac arrest in the hospital, drag me out to the ambulance bay, call 911, and once you get me back, you can bring me back in. But I think the reason that's important, your comment, is we bring patients in with the Lucas device or the AutoPulse, and what does the ER doctor do? They take it off. There's an eye gel in, they rip it out. And so my medics come back to me and say, are we really taking these patients to this hospital? So I think the hospital should learn a lot from what EMS is doing rather than the reverse.
Well, let me say this, though. I think that, I think that's applicable to all prayers. What Diane so nicely says, that these folks do it all the time. You might get the resuscitation team du jour, that shows up. They don't do it regularly, so that's part of it, is maybe having the specialization there. But even if I look at even our busiest fire trucks in our city that you say, where's the highest level, highest percentage or volume or frequency of cardiac arrest, an individual on that team may not get to perform the CPR. Even if they have 3 cardiac arrests a month at that station, that individual on a given shift may not get to do it that often. So that's why I'm kind of enamored of the concepts of things like the things that the Heart Association has put out, like that CQI thing. I'm not promoting, I don't have any interest or anything to promote it, but the concept that where you can get someone and make sure they're just performing as part of their tasks in the station or at the hospital, just to keep their skills up, even just for the muscle memory part on a regular basis, may be a really worthwhile thing. And so that applies to the out-hospital level of the in-hospital region. Peter?
Peter Talak, Salt Lake City. Just as a aside on that, a benefit, you mentioned having the EMS guys come in and maybe monitor some of the work, but actually doing the team approach, the pit crew approach that is being developed and teaching that to the hospital staff would be of good value, I think.
So at this point in time, we're probably, if there's no other questions, that's good timing because I've got to bring Tom up, and we have some special guests here that we're going to bring up. And so does anybody have any other comments or questions? I just personally wanted to thank, at least for the area where I worked in, the breakout session, everybody contributed just brilliant things. I learned a lot, and it got me buzzed about doing new things. So I hope that was the case for everybody else here today. So I wanted to actually give a round of applause to all the people who contributed in the breakout session. Okay, and with that, please welcome to the stage the Master of Ceremonies, Dr. Tom Albright.